Well, thank you very much, Mr. Chairman, dear colleagues. Thanks to CytoSorb for the kind invitation to give this talk. Indeed, my talk is going to be about the emergency surgical patient under Ticagrelor. As you know, Ticagrelor, as a surgeon, is a very potent medication. This is a selective, reversible, but selective inhibitor of P2Y12, which is the platelet membrane receptor for ADP. By inhibiting this receptor, this medication is a very, very potent antiplatelet medication. And as surgeon, we have to face those patients who are on Ticagrelor, and we know that this can be a real nightmare if you have this patient on emergency basis, coronary acute syndrome, or acute dissection, or other. Then those patients, they can bleed to death. And the problem is that we will have to face, more we will go and more we'll have to face those patients under this kind of medication, because if you look at the recent guideline from 2017 from the European Society of Cardiology, they say that dual antiplatelet in the form of aspirin plus Ticagrelor or prasugrel is recommended for 12 months after PCI, unless there are contraindications such as excessive risk of bleeding. The problem is that the excessive risk of bleeding, usually you don't know about it until you got it. So this is why we will get, more we will go and more we will get those patients to operate on. And the problem is that even for planned patients, for the patients who are scheduled for surgery, sometimes it's not so easy to take the decision to stop the Ticagrelor before the surgery. If they do have very bad coronary artery disease, I operated one patient like this yesterday. This patient, he had very bad coronary arteries with very bad result of the stents, and no one wanted to take the responsibility to stop the Ticagrelor before the surgery. So, of course, during surgery, this patient bled a lot. Fortunately, after that, the patient did well. But this is something we have to face because if we stop the Ticagrelor in some patients, even for scheduled surgery, we have a high risk of thrombosis. On the other hand, for the emergent surgery, we have those patients coming to the theater, and they have a high risk of bleeding. And the problem is that after the surgery, if you transfuse the patient with platelets, then if they do have stents, again, there is a high risk of thrombosis as well. And we did have some patients who finally did well during the surgery, but they had stent occlusion after the surgery because of platelet transfusion. So, as you know, CytoSorb is a pretty easy device, very easy to connect on the CPB. So I'm not speaking about the CytoSorb on the dialysis machine. I'm speaking about the CytoSorb on the CPB, which is just in parallel to the normal circuit. So just very easy to add that to the normal circuit. You can even do it during the surgery, even while the CPB is running. It does not need any other anticoagulation or whatever. So pretty easy to use. So, of course, there is not too many literature on the topic. This is one paper looking at the bench, looking at the device on the bench, and they did look at the removal of the Ticagrelor by the CytoSorb on fresh blood and fresh plasma. So, as you can see, this is the fresh whole blood, this is the plasma, this is the % removal of Ticagrelor after 3 hours, 7 hours, 10 hours. So when they did show on the bench that the CytoSorb device was very efficient to remove up to 90% of the Ticagrelor during the first 3 hours, and even up to 98, 99%, almost 100% of the Ticagrelor after 7, 10 hours. So this is a pretty powerful device to remove these molecules from the blood of the patient, at least on the bench. Another medication I want to talk at the same time is about the rivaroxaban, because there are some of the points in the literature looking at this medication as well, and I think we can treat both together. As you know, the rivaroxaban is a very potent inhibitor of the TANA for the coagulation. And again, there is one very short paper showing that CytoSorb is efficient as well to remove the rivaroxaban from the circulation of the patient. So this device can do both, take out the ticagrelor and take out the rivaroxaban from the circulation. And this is important as well because I told you more we will go, more we will get patients on ticagrelor, but more we will go, more we will get patients on rivaroxaban as well. And now we see that, at least in France, many patients who have coronary artery disease and they are treated because of this COMPASS trial, they are treated with aspirin and rivaroxaban together because they did show that adding the two medications for those patients with very bad coronary artery disease does significantly decrease the risk of cardiovascular event. Even if they do have an increased risk of bleeding, they treat those patients like this because they know that those hemorrhagic complications are not fatal. On the other hand, they decrease, really significantly decrease the rate of cardiovascular complication. So this is one trial, one study, which is not a randomized trial. This is a prospective observational trial in human looking at CytoSorb in removal of ticagrelor and rivaroxaban in human during cardiac surgery. So this is the paper from our colleague from Hamburg. It includes 55 patients, emergency patients only. 43 were on ticagrelor and 12 were on rivaroxaban, and you can see that 39 were treated with CytoSorb and 16 were treated without CytoSorb, and they did compare both groups. Of course, this is a small study. You know, we don't have a lot of patients in the literature right now, but at least this study gives some kind of answer regarding the efficiency of this device. So it was a 2-year trial, 55 patients, and you can see that 39 were treated with CytoSorb, 32 on ticagrelor, 7 on rivaroxaban, and 16 were served as a control group. If you look at the baseline of the patient, they were very similar. These are the patients with CytoSorb, these are the patients without the CytoSorb, and this is ticagrelor and rivaroxaban. Most of the patients were very similar. The RO score was almost between 3 and 4. And if we look at the kind of surgery they did get, so all the patients did have coronary artery disease, and finally most of them did get CABG, isolated CABG for 34 in this group and 15 in this group, and some other did have CABG associated with aortic valve disease. There was one patient with acute aortic dissection. Well, if we look at the duration of the procedure, the timing, you can see that this here, so this group is the ticagrelor group, CytoSorb plus, no CytoSorb, and this group is rivaroxaban with CytoSorb and without CytoSorb. You can see that regarding the CPB, it's pretty similar from one group to another group. Regarding the cross-count time, it's pretty similar from one group to another group. But the procedural duration, which finally is related to the end of the procedure after the weaning from the CPB, the duration of the procedure was way shorter for the patient who were on CytoSorb in comparison to the patient who did not have any CytoSorb, showing that maybe the hemostasis time at the end of the surgery was more easy in the group of patients who did have CytoSorb. And this is what we see when we look at the rate of transfusion of those patients. This is the red blood cell transfusion, platelet transfusion, and you can see that if you just look initially at the ticagrelor group, more than 3/4 of the patients who were on CytoSorb did not have any red blood cell transfusion, although only 50% of the patients had no red blood cell transfusion for the group who had no CytoSorb, and the difference was even bigger if you look at the group of patients who were on rivaroxaban. And finally, if you look at still to the red blood cell transfusion, finally you can see that more than 30% of the patients did require red blood cell transfusion for the group of ticagrelor without a CytoSorb, and 80% of the patients who were on rivaroxaban did require red blood cell transfusion. Looking at platelet transfusion, the difference again is really in favor of CytoSorb, and this is a significant, very significant difference, showing that many of those patients, or the patients on CytoSorb, did not require any platelet cup transfusion. On the other hand, all the patients who did not have CytoSorb did require a platelet transfusion. So you can really make a pretty good economy of blood product transfusion by using this device, if we look at this study at least. Of course, the amount of bleeding, the drainage volume was very different from one group to another group. This is the group without the CytoSorb here, and this is the group with CytoSorb. If we look at the numbers, if we look at the numbers, you can see that the patient who had no CytoSorb finally had almost double drainage volume in comparison to the group who were treated with the CytoSorb. And finally, thoracotomy rate was significantly different between the groups because there was no thoracotomy in the group of patients who were treated with CytoSorb in comparison to the patients who were not treated with CytoSorb. And because of that, the duration and the length of stay in ICU was significantly different in favor of the group of CytoSorb, and the total length of stay was even significantly different in favor of CytoSorb. So again, I don't know what is the price of this device. At least I don't know in France what is the price of the device. It's not easy to get reimbursement. At least you can get some good economy for blood product transfusion, and as well regarding the length of stay of the patient in the hospital. So if we finally want to summarize this trial, by using the CytoSorb, we had a shorter duration of procedure, a lower degree of transfusion for red blood cell and platelet, a lower degree of drainage volume, no thoracotomy, and shorter length of stay in the hospital. So the conclusion of this trial was that the intraoperative use of CytoSorb hemabsorption in patients with Ticagrelor or rivaroxaban treatment undergoing emergency open heart operation is a safe and effective method to reduce bleeding complication and to improve post-operative outcome. And they do recommend in this trial, they do recommend the use of this device. In our institution, in La Pitié, we do have the experience, I think, 6 or 7 cases of patients who were on the antiplatelet medication like the Ticagrelor. We did use the CytoSorb, and I can tell it did work pretty well. Even we had 2 patients who were on rivaroxaban because they did undergo transplantation. And again, it was pretty good to have this device to help the care of those patients during the CPB. So in conclusion, I would say we will have to face an increasing number of cardiovascular patients treated with potent antiplatelet and direct inhibitor of TNA factor. Pre-op withdrawal of those medications and emergent surgery requirement make those patients high risk of thrombosis and bleeding. So this device, CytoSorb, is efficient to remove molecules such as Ticagrelor and rivaroxaban. So CytoSorb added to the CPB circuit has beneficial impact on drug-related complications and seems to be cost-effective. Thank you very much for your attention.